Hello, everybody, and welcome to another one of our ultra-popular and hopefully ultra-helpful Fertility 101 episodes. Today's topic is one that I know is on a lot of people's minds when they just enter the world of fertility and family building. Today, we're going to learn about common tests for fertility and infertility. I'm Dan Bulger with Progyny, and this is Infertility. Today's guest is Dr. Paul Dudley, Medical Director at Pinnacle IVF in Atlanta. Dr. Dudley is a reproductive endocrinologist, so a fertility expert, and he's going to help us break down all of the most common tests that you might run into when evaluating your fertility. So, in order to understand this, we really need to know what we're talking about when we ask the question, am I fertile?
Well, you need to be ovulatory. You need to have sperm. You need to have a reasonably normal uterine cavity and at least one fallopian tube that's open. You need to have an adequate frequency of timed intercourse. And then the big one is ovarian reserve.
Okay, so that's a really high-level overview of what we're looking for. So let's break down how we test for each.
I'll actually begin with the question of frequency of intercourse, because some of these practical questions are among the most common ones that folks encounter. As far as frequency of intercourse, there's data to suggest that folks who are attempting to conceive via timed intercourse like once a day, right around the middle of their cycle, that there may be some incremental advantage to doing that, but that's got to be balanced against the very real burnout that most couples will begin to experience. And frankly, I would say they will inevitably experience if they're attempting to do that. Most sperm's going to survive in people for several days. I would say that in the human population is in the billions, and it's not because people are using timed intercourse and apps and this and that. It's like we were sort of made to reproduce. So if folks are having 2 or 3 episodes of intercourse right around the middle of their cycle, that's probably a reasonable amount of frequency.
Okay, so yes, the first thing is intercourse. Is it happening frequently enough to realistically have a good chance for pregnancy? And is it happening at the right times during a woman's cycle? When people do see a doctor, there are a few standard tests to get done right away during that initial evaluation.
The semen analysis, most guys need to abstain from ejaculation for about 2 to 5 days, meaning no ejaculation of any kind prior to collecting that sperm. And then in women, we assess the tubes, ovulation status, and ovarian reserve, typically in one visit. So usually that doesn't necessarily have to be in the first half of the menstrual cycle, but our patient population is busy. They have demanding lives, they have demanding jobs oftentimes, and they don't need to be here every other day getting their blood drawn and getting an ultrasound. And we try to consolidate things into one visit. So for instance, that individual, we would usually have them come in right around the tail end of their follicular phase, which would afford us the opportunity to both assess their ovarian reserve via ultrasound and blood draw, which I'll describe in a moment, determine or confirm that they're ovulatory just based on the combination of regular predictable cycles and the presence of what's referred to as a dominant follicle, i.e. a small cyst with an egg that's clearly going to be ovulating in the next coming days. And then we typically would perform some sort of uterine evaluation. Classically, that might be a test called a HSG, which stands for hysterosalpingogram, hystero meaning uterus, salpingo meaning tubes, gram meaning imaging of. And that is a test that confirms it's both diagnostic and therapeutic. Diagnostic in the sense that it tells us that someone's uterus and tubes are within normal limits. Therapeutic actually in the sense that the act of flushing out one's tubes is kind of a good low-tech fertility treatment. We sometimes will perform the HSG. There are a couple of different alternatives that we employ at times in individuals, kind of depending on their history, their medical history, surgical history, and those could include things like a saline-infused sonde histogram, where you fill the uterine cavity with a little bit of fluid and get a better view of the wall of the uterus at the time of the procedure, or an office hysteroscopy, where you are directly visualizing the interior of the uterine cavity. But all of that is consolidated into one visit, and then with any luck, you get both a combination of lab results, semen analysis, and ovarian reserve testing, such that by the end of that cycle, so even 7-10 days later, you're following up with the patient and you're breaking the whole thing down. You're saying, here's what we did, here's what we found, here's what the plan is.
While the world of fertility and fertility treatment can oftentimes be complex, Most of the tests that Dr. Dudley just spoke about are actually fairly straightforward. It's pretty clear for a doctor to see if a fallopian tube is blocked, for example. But things get less straightforward when we start talking about ovarian reserve. How many eggs are there? And most critically, what is the quality of those eggs?
Ovarian reserve really has two components. One is quality, which tends to trend with age, and the other is number. And women are born with, in some cases, millions of eggs, and those eggs gradually decline over the course of a woman's life. People think of, say, 35 or 40 as being this magic number where after 35 it craters. That's not the case. These are just points in a curve. Better way to think about it is that at each age point in a woman's life, there are measures of dispersion. You have women who are born, take 32, for example. You have women who are born on the high side, who are destined to go through menopause at 58. You have women that are born on the low side, who are menopausal in their 20s, and everything in between. Now, in a perfect world, we would be able to hook up women to some sort of meter and say you have, 24,832 eggs left, but that's not possible. Now, however, you can get an idea of kind of a spread, which is a typical sort of bell curve where you have a lot of women in the middle, they're average, some people high, some people low. You can't really refine it much more than that. But the way you refine it and the way you group it into those individuals and can make some assumptions about what their reproductive window might be is based on the combination of their age. That way you know which curve applies to them, their ultrasound findings, and their labs. And ultrasound findings, this is, again, something that you come back when you do that first ultrasound mid-cycle. You're assessing what's called the antral follicle count. The antral follicle count has to do with antral follicles, or we just kind of shorten it and say follicles. Antral follicles or follicles have, if you look at someone's ovaries, let's take a woman who's 32, and rewind the clock back. We hop her in a time machine. She goes back in time. We're looking at her ovaries now. When she was 25, that individual's ovaries are going to be physically larger than they are today. And you would see more follicles visible in ultrasound than you do in the present day. Those follicles are, if you were to count them, let's imagine you counted them and there were 20. That doesn't mean that person only has 20 eggs left. In fact, those 20 eggs are really just kind of the proverbial tip of the iceberg, where the totality of that woman's ovarian reserve, which is typically in the many, many thousands at that stage, again, if not more, are in fact kind of resting beneath the surface. But how many that woman has, or how much that woman has in ovarian reserve in terms of the total amount of ovarian reserve, influences the number of follicles, the number of eggs that are available in any 1 month. So the brain kind of looks at those hypothetical 20 eggs and has no special insight into which of those eggs is the most likely to yield a live birth in that month. In fact, it just kind of randomly picks one based on a little bit of timing. It selects that one egg to release, and the remainder just are absorbed through something called programmed cell death. And in doing so, that's how that woman's ovarian reserve gradually depletes over time. If you think about it, a woman doesn't ovulate all of her eggs over time. The overwhelming majority are just absorbed.
So as time goes on, the number of eggs a woman has in her ovaries goes down. And while egg quantity does impact fertility, the perhaps bigger and trickier measure is egg quality.
It's kind of a catch-all term that really refers to the fact that when women are younger, the prevalence of genetic abnormalities in the eggs that are available in any one cycle is lower. The inverse of that being that the prevalence of normal eggs is higher. And as they get older, those eggs that they are still releasing, that prevalence of abnormal eggs increases. That manifests itself as eggs that are being released, but simply are incapable of fertilizing, dividing, implanting, miscarriage, and forbid a baby with a problem. But that's why in societies that prior to the advent of means of contraception, that's why the live birth rate declines precipitously. It's just because it's not that women aren't having intercourse or that something that inherently becomes wrong with the uterus. It's because the eggs themselves begin to, or are far less likely to yield an ongoing live birth. And some of the same things happen in men. It's just that those manifestations are much, much later in men's life.
Okay, so the main tests are what we just listed. A blood test that looks at your anti-Müllerian hormone, or AMH, which can provide some information about ovarian reserve. Your age is used as a guide for egg quality. An ultrasound to look at the ovaries and the uterus. An HSG to see if the fallopian tubes are open. And for men, a sperm test. If any issues are found, more tests might be needed. Like for men, if there's no sperm, perhaps they'll need to be referred to a reproductive urologist for further testing. We have a lot of videos about that, so go check that out on our Progyny YouTube channel. But now you might be wondering, well, it's 2024. Certainly some of this can be done at home, right? It's a good question, so we asked Dr. Dudley what he thought about fertility tests that can be done at home.
There's two different classes of at-home tests. I would say there's kits that are sent to reference labs, and those are reliable. Yes, these are things like where kits that there are kits that you can order through Amazon to do things like little mini microscopes and of the like to evaluate your semen analysis. No, those aren't. I wouldn't describe those as being helpful, and even the some of the at-home diagnostics can lull folks into either a false sense of security or excessive anxiety, because with all of these assays, there's variance and the evaluation is not comprehensive. So I would say it depends a bit on why someone is doing it. If they're doing it for the purpose of almost in lieu of so checking your AMH via home mail order diagnostic kit in lieu of getting an AMH performed at your annual exam, if you're a woman, I think that that's probably fine. If on the other hand, someone is experiencing trouble conceiving, if you're to the point where you're ordering one of these things, you're contemplating it, in general, I would say it's probably best that's time to talk to your OB or talk to your reproductive endocrinologist. Yep.
Okay, so we've spoken about the basic fertility evaluation testing, but now let's look at these tests in action. We're doing these tests to figure out if there's anything going on that can be causing infertility, right? Well, let's kind of look at it backwards then. How might looking at the tests like the ones we've discussed lead to a diagnosis for something like polycystic ovarian syndrome, or PCOS?
Specifically with polycystic ovarian syndrome, that's a disorder that's associated with a combination of irregular menstrual cycles. The fancy word for that is oligomenorrhea, which is essentially saying that the person is having infrequent menstrual cycles attributable to anovulation. So their menstrual history will give you a hint at that. Although the differential diagnosis, that's the term in medicine we use for like, hey, this person has this symptom. In this case, oligomenorrhea was the differential diagnosis. It's huge. You then combine that with other hints of things like clinical or laboratory evidence of androgen excess. These are some of the male hormones in women can be a little bit elevated in women with PCOS, and that's detectable either just based on symptoms or based on laboratory testing, and then ultrasound findings. So again, if you had someone, if we went back to that first sort of 5 things that I was talking about evaluating whether or not someone's ovulatory, well, if they come in around what ought to be around the middle of their menstrual cycle, or particularly if they report irregular menstrual cycles and they come in and you do not see an ovulatory, there's no evidence of ovulation and their ovaries meet criteria for what's called polycystic ovaries on ultrasound, then that would then start a whole cascade of additional supplementary testing that's performed, because PCOS specifically is a diagnosis of exclusion, meaning that it's not a binary test like you're pregnant or you're not, or that person has prostate cancer or they don't. It's a combination. Syndromes in medicine are when you have a combination of symptoms, you rule out these other potential causes, and you say, hey, you have these specific criteria, we rule out this other stuff, therefore this person has PCOS.
Okay, so when someone has PCOS, doctors use these tests to rule out other issues and then can confidently provide a PCOS diagnosis, which would come with its own strategy for treatment. But what happens when all of these tests come back normal, yet infertility is still an issue?
Sure. Idiopathic or unexplained infertility is traditionally diagnosed only after laparoscopy to rule out endometriosis. But nowadays, so alluding to before, we're comfortable labeling someone as having unexplained infertility prior to or without performing the laparoscopy itself. A lot of unexplained infertility is what I would call subtle male factor. The semen analysis is a relatively crude assay. It's unchanged for decades. And many times women think it's me. And in reality, it's him, or it's at least him's making a big contribution. But more often than not, it's not any one thing. I would sort of draw a distinction between kind of the bucket model of diagnosis or etiology or cause, and instead think of it as a threshold model, where in the bucket model, you have people that they have male factor. Okay, they fall in that bucket. Or you have endometriosis, that's the bucket. When in fact, it's more likely to be a kind of a threshold model where if you imagine sort of a threshold above which people begin to experience subfertility in any 1 month, you can have a combination, subtle effects of age, subtle effects of timing, subtle effects of semen analysis. That additive effect is what gets them over the threshold in any 1 month and make any one cycle less likely to yield an ongoing live birth. And then you stack those cycles up, and it's not hard to see how that individual can go many months or even more without conceiving. Which when you approach it that way, that kind of gets at the key of what we're trying to do with fertility treatment.
All right, so that's fertility treatment 101. We know that infertility can be distressing, and the testing can feel overwhelming. We asked Dr. Dudley if he had anything he could add for anyone listening who might feel overwhelmed.
Many of our patients are themselves accomplished individuals who have been taught and have experienced that the more I apply myself to something, the more likely it is that this is going to work. Like the more I study, the more likely it is I'm going to get the outcome that I'm hoping for. And this is really not like that. What I would tell folks to do is to focus on the things that are within their control, which are actually, they're simple, but that doesn't necessarily make them easy. And it's things like get an adequate amount of sleep, find a healthy outlet for stress, don't smoke anything, either don't drink any alcohol at all or do so sparingly, exercise consistently. And then everybody has room to clean up their diet. There really is no such thing as a fertility diet. It's just linear fruits and vegetables, a bit of meat if that's your thing. Cook most of what you eat. That way you know what goes into it, and probably don't eat until you're completely full. If you're doing those basic things, it's the stuff that we learn in the 5th grade, but very few of us do as adults, then you're doing what you can that's in your power. And then the next step is that if it's not working out, you find someone that you trust and follow their advice and try to be an informed patient. You want to ask good questions. You want to approach every appointment with good questions about, here are the things, and write them down. That's what I would do. But then try to turn over some of that thinking to them. Otherwise, so much of what can be damaging in fertility treatment, again, it impacts, it's the intangibles. It's the negative impact on relationships. It's the negative impact on mental health. And you want to get on the other side of this whole process unscathed if you can.
Yes, it's important for us as consumers of healthcare to be informed. And there are many times during any treatment journey when we really do need to make sure that we're being our own best advocate, asking the right questions and making sure we're getting the support that we need. But that being said, it's crucial that we also rely on our experts, men and women who share our goals and have dedicated their lives to solving these problems. I want to thank one of those experts right now. Thank you to Dr. Paul Dudley for being on the show with us today. And of course, I want to thank you for joining us too. If you want to connect with us, you can do so at Instagram at This Is Infertility Podcast. If you want to follow Progyny, you can do that at Progyny Inc. Of course, if you're listening on a podcast app, please leave a rating and review. That's a huge deal for us. And if you're watching on YouTube, please leave a like and subscribe. This Is Infertility is brought to you by Progyny. Please remember, this podcast is not intended to substitute for the personalized expert advice of your physician. I'm Dan Bulger, and this is Infertility.